Thank you. Once again, thanks to the organizers for having invited me here. It's an honor and pleasure to be here. I'm going to talk about cataract surgery in patients with corneal opacities, from planning to surgery. For sure, when you have these two pathology, corneal opacity and cataract, you need to deal with them. And for sure, the cataract is for surgery. But what about the corneal opacity? Should we perform surgery? Maybe it's not in the stage for surgery. But if the cornea needs surgery, should we treat both conditions in the same surgery or in sequential procedure? The answer is the decision is customized. It depends on the position and severity of the corneal opacity and of the easy access to a donor cornea, as you will see. There are some preoperative concerns related to the surface assessment, the tear film evaluation, corneal sensitivity. An important highlight I would like to tell you about the neurotrophic keratopathy. It can worsen after cataract surgery, so pay attention to its presence. And in terms of biometry, I think this is the main issue preoperatively, because you have opaque and irregular corneas, and for that you have difficult and unreliable K readings. I'm not gonna insist too much, because it will follow two very interesting presentations on this topic. But related to the biometry, you need to use modern machines and modern formula, and I highlight also the importance of the refraction history and the refraction of the other eye. In terms of type of IOL, my opinion is that you better use monofocal standard IOLs, because the premium IOLs don't fit usually with this kind of pathology. Another highlight related to the instability of the cornea, like in previous penetrating keratoplasties with suture in place. The refraction will change after you remove the sutures, and in the previous radial keratotomies, again, you have unstable cornea and you can have hyperopic shift after your correct biometry. So I'm not going to insist on pre-op concerns. I'm going to go directly to intraoperative concerns, from which the main one is the visualization issue, which is not the case in the cases associated with concurrent penetrating keratoplasty, where you work in open sky, but it is a case when you deal with lamellar keratoplasties. And you also will see you might have some problems when related to the incision sealing and closing issues, like interior ulcers. Let's see the first case. Here it's a congenital aniridia. The plan is to operate the cataract, implant an IOL and artificial iris. The opacities are in the periphery, so you don't mind too much, let's say, or at least you think you don't mind too much about the visualization issues. But as you will see in this case, you need to be very precise in implanting the iris, artificial iris, because it needs to be in the bag. So that's why dyeing the capsule was very helpful in implanting this iris in the bag, because you need the specific size of the capsular rhexis in the small eye with thick IOL. And this is another example with peripheral opacities, Terrian ulcer in this case. Of course, no problem with the visualization, but you have a lot of problems with closing the incisions. And you will see at the end, this patient was supposed to have and had a toric IOL, but I needed to suture the incisions. And even so, you see the anterior chamber was unstable. I injected air and I still had leakage. At the end, I needed to put even 2 sutures on the paracentesis, but this patient did very well at the end after 1 month when I removed the sutures. What about the cases when you have central corneal opacities? Of course, the visualization is a real problem. And there are some tips and tricks. For example, turn off all the lights in the OR, make it as dark as possible, increase the zoom, enlarge as much as possible your area of visibility, use iris hooks, use capsule dye. Of course, sometimes you can use lateral retroillumination and work in a more visible place. I mean, you can move your tip with the pieces of nucleus a bit laterally to the leucoma, so you can see better, and at the end you can have a safe procedure. I will go further. When you have a combined procedure with penetrating keratoplasty, visualization is not a problem, but with lamellar keratoplasty, it really is, like in this case. So this is a Fuchs dystrophy. Of course, you need to, and you want to perform a lamellar, posterior lamellar procedure, DSEC or DMEC. I chose DSEC in this case. And the visualization is really very poor, despite I did all the previous tips and tricks mentioned in the slide before. But again, you can bring, in this case, you don't mind about the endothelium, so you can bring your pieces, nucleus pieces in the artery chamber and work more anterior, so you can have a safe posterior capsule. At the end, the DSEC or DMEC goes absolutely normal, as in a standard procedure. This is a similar case, but what I did here, I removed the epithelium from the beginning. Usually you don't want to remove it from the beginning because the stroma can inflate and can worsen your visualization, but here I had to do so. And I brought the nucleus in front of the iris and worked in the anterior chamber. This was very helpful because I worked, again, peripherally, even on the iris, because I didn't mind about the endothelium, but you do mind about the posterior capsule. You want it to be safe. And the last video, it's about penetrating keratoplasty, cataract associated with penetrating keratoplasty. It is a case with corneal abscess and perforation. And for this, the patient had small pupil, uveitic reactions, and sometimes you ought to know the old-fashioned extra cap extraction, because sometimes you need it, like in cases like this one. But be careful not to remove too quickly a lens which is very thick, like in this case, because you don't want to have expulsive hemorrhage. And you can choose to implant the IOL at the end of the surgery before you put the last 2 sutures. In conclusion, cataract surgery in the presence of corneal opacities need a detailed planning and must be tailored on each patient according to several things, among which the size and location of the corneal opacities, the cataract severity, and the surgeon's experience and preference. Thank you.